Hello and welcome back to the Sports Medicine Project. We're going to keep it very short today, 10, 15 minutes max, and we're not going to go over 10 max. If we're talking, I'm just going to cut it and hit it, and whatever you've got, that's what you've got. So we're going to be talking about a pathology. It's easily the most common thing that I see, and it's one of the most common lower limb conditions in the world, and not just the running community, but just overall in any human, and that is plantar heel pain. How often do you see it, Kelly? I know podiatry sees it a lot, but what about physio?
I definitely don't see it as much as you, but it is common. Like, we do see a fair bit of it. I actually really like treating it. It's probably one of my favorite conditions to treat, I'd say, if it's the more tensile type.
Let's quickly talk about that. And we're not going to talk about all the differentials, and not all heel pain is plantar fasciitis or plantar fasciopathy. When we talk about the two differences, and we call it plantar heel pain because we think it's more of a syndrome, and we think it's more than one structure kind of angry and irritated. And when you push into the heel, there's no way to really know what structure is actually sore because you're pushing into a lot of structures. So attenuative versus compressive, you'll find with some patients, they have pain going up into a calf raise, or on tiptoe walking, or on hopping, and they'll feel, a pull or a stretch or some pain down through the arch into the base of the heel. And they don't really get much pain when they're walking on their heel, compared to some patients where it's the opposite. They put pressure through their heel and they have this kind of central medial irritation on palpation. So generally it means the forces that are being applied to the body are attenuative, meaning you're getting tension along that plantar fascia and those structures. That's what causes the pain, compared to a compressive pain when the heel strikes the ground and you're having that big ground reaction force come up underneath. Now, I think the treatment differs quite a bit. Basically, one gets loading and one doesn't. And what do you think, Cal? You add anything to that?
Yeah, I mean, it's definitely easier. I assess very similarly to what you just said, and probably because you taught me how to do that. But I still think that some sort of offloading for a more attenuative type can be beneficial. Like, for example, like low dye taping can be useful, I still think. So I don't think it's as simple as it being one or the other. I do think that there can be some crossover, probably more often than not.
Yeah, no, you're right there. And I apologize, that there definitely is crossover. I think that, and we can say this because I'm a pod and you're a physio, the issues that I see with physios when they come and see me is they've been giving all this loading and strength and conditioning and calf raises, which is great. But when it's that compressive nature, it just needs a bit of a cuddle and an offload. But then I also know that I have, in my profession, patients that go and see physio and they're like, all the podiatrist gave me was heel lifts, orthotics. They didn't give me any strength and condition. They just gave me calf raises. So they're the kind of two things that we see and we hear. And I think using a combination of both probably works better. Would you agree?
Yeah, I agree.
So for the compressive one, my kind of general treatment is, one, to work out that it obviously is, that compressive plantar heel pain. And I'll explain to the patient that, we just want to give the foot a cuddle, try and offload it as best we can in the short term. And generally that means giving them an inner sole. Doesn't have to be custom. Usually it's just something soft, and it's just more to have a little bit of shock attenuation. I would even try some heel lifts underneath just to bring the center of mass forward, take it away from the heel. I usually do take their foot, and I see how irritable they are into loading. If they can tolerate calf raises and things like that, I'll give them that. And then obviously relate that back to what they want to be doing. If they're a runner, we might look at reducing their running by 20%, 30% and seeing where they sit. And not too often people are stopping running unless it's like a tear or something severe. But definitely always relating it back to what's meaningful for them and trying to play around to find what's enough to wake it up without flaring enough. And then giving the foot a bit of a cuddle. And low dye taping works well. Sometimes
I like that. Wake it up without flaring it up.
Yeah, that's the Justin Smith.
That sounds special. Like a Justin Smith special.
Yeah. So we do that. Sometimes give them a compression sock, do a bit of taping. And I know everybody treats very much the same. I just think it comes down to the education of, it's a very hard area to offload. You're always walking through the heel. It doesn't get much of a rest. So it takes a little bit longer, I think, in most cases, but generally we see pretty good outcomes. And if it's chronic, I might look at shockwave earlier on. but I usually see how they go with an initial response to those offloading techniques. What about you? How do you do it?
I was just sorry, you asked me a question, but I had something I needed to say in my head, and now I'm confused. I was just thinking, so evidence-wise, there isn't much to support the use of like cortisone injections in
heel pain
to fasciopathy. What about if it is more of like a compressive type where it's a, say, like a flared up bursa or a flared up fat pad? Is there use of cortisone injections in those cases?
Unfortunately, I haven't seen it, the condition differentiated in the research to say this is an attenuative one. Usually it's just plantar fasciopathy.
Yeah,
that's what they call it. And it's the umbrella. Again, I've heard the patients that I've seen, they say that PRP is painful and cortisone is bloody painful. And I've had some that it's worked wonders and they never had any pain again, but the majority say that it didn't do much. Or the worst is when they get an injection for a bone spur. That's the worst. And I was I don't think the bone spur is causing the pain. But what's your general, what do you look at in the initial for someone?
I will do similar to what you said at the start. So I'll try and sort of decipher, and a lot of it comes from their history as well, of if it's more likely to be a compressive plantar heel pain or a attenuative plantar heel pain, or what seems to be the more aggravating factor. I'm just thinking about a patient that I have at the moment who I've actually just sent off to the sports doc, who was seeing you guys last year actually for a more compressive plantar heel pain, but didn't really respond as well as you would expect. And then I started treating them for something else, and then it sort of evolved into like, let's just see how your heels tolerate some sort of loading and a bit of a return to running program. And they did a little bit, but just not as much as you would expect. So it's a bit of a weird one where it like hasn't responded to loading, but then also hasn't responded to offloading either. So that's one where I'm like very happy to send off to the sports docs, because it's not the result that I would anticipate. So I want to be sure that there's not something else underlying going on.
And if you even have like a low grade, and I've seen that a couple of times, and I know there's a patient I'm thinking of, had like a low grade stress response to the calcaneus. Like they can present as well, and they don't always present like a stress fracture. So that's an interesting one. I think, again, and we know it does take a while, and I know the research is like 12 to 24 months for some chronic heel pain, but I think that you should see a response pretty, not quickly, but pretty in a short period of time. Like you should be seeing, because you're offloading it, like it should feel better, I think, and sometimes it's hard to offload it, but not too often they're coming back and saying it's worse. They either say it's a little bit better, it's heaps better, or it's a little bit better, but then they're all like doing more. So like, it's not much better, but now I'm running 5 kilometers, or now I'm doing my meaningful activity. So it's interesting. I know there's some research to support custom orthotics in plantar heel pain. I'd be interested to see that study with prefabs, and I think maybe there was one. I can't think of it. I definitely think that soft inner soles do have play an important role in those cases that aren't improving. And I would encourage people to collaborate and work, with your local podiatrist to see. Not all cases need it. Definitely not. The majority probably don't. But I think that there is some case, because it's just in my opinion, it seems to be the most logical way to offload someone without putting them in a wheelchair or a moon boot. What do you think?
I've never put anyone in a wheelchair.
Yeah, but I use that analogy with patients when I'm like, this is why I'm doing it, because trying to offload this thing, it's bloody tricky. It's hard. You strike with your heel, like the only other way to do it is here's some crutches, so that's what
which is not a good idea.
No, definitely not. Definitely not. And again, I've put some heel pain patients in boots before, but I think that's
really
few and far between. When I
was concerned, was that indicated?
There was a couple I was concerned of a tear.
Even with a tear though?
Yeah, even with a tear, just because I don't want them to. I could use even with a tear. I was concerned that they tore it, because what's the risk versus reward? The risk is that they do something worse, and I guess they do something worse, and perhaps they're in a boot for they usually get the ultrasound in a couple of days. What's the worst that can happen? Like, they're not going to lose that much capacity. And it gives me peace of mind to say, great, you don't have a tear. I'm just more confident. So I would rather do that, I think. I know there's a better way to explain it, but I can't think what it is. And a couple
I guess
others
if it's an acute tear, that makes sense.
There's a couple others that have just been incredibly painful. And they're just like I've had people, in tears. It's a debilitating condition. And I'm like, I can't, this is what I can do, but it's not going to be the best option, but it's the lesser of two evils, Yeah. So pretty good. And then from all those kind of offloading techniques, then it's just rated exposure. I've got to admit, I do take them further, like calf raises, single leg calf raises, and then I'll get them, hopping and jumping, and then I'll get them walking and hopping and jumping on their heels, because I want their heel to be able to tolerate it. I don't know if you do that. Maybe I
haven't done that.
Yeah, I get them doing that.
Feet, that would be fucking painful.
Yeah, but you think that's what your foot is subject to. So I want to be confident that they can tolerate that. Again, I'm not doing it early on, but I want to basically expose the body to a
Do you keep their shoes on?
Oh, it's not. They're not jumping off a 5-meter building. Like, they're just doing some little hops.
I still reckon that hurt. Hey.
Yeah, not when they're in pain. Like, this is the last 5% of their reading.
Right now, I don't have heel pain, but I don't want to jump on my heels.
Yeah, well, we need to get you built on some tolerance. Again, not with everybody, but with some people, I might do it, 1, to give them confidence, and 2, to be like, this is the load that your heel is going to be subject to. I'd like to kind of expose you to that. So the next time you are exposed to that load, perhaps you're not as uncomfortable. It's interesting. I don't do it with everyone, but I'd love to hear some cons. What do you think? Probably shouldn't do that.
I don't know when anyone needs to be putting that much direct force and load through the heel of their foot in a day-to-day setting.
What about when they, I guess. Yeah. And I don't think... I have done it. And I don't do it often.
What are you trying to strengthen, their calcaneal bone process?
But this is the thing, it's not about strengthening a particular structure. In my mind, it's if I expose the tissue to a certain load in, its window of effectiveness, and then give it time to recover and adapt, that tissue is therefore stronger. Do you think? Same as if when I'm hopping and jumping, my joint capsules will become more resilient to hopping and jumping. I'm not strengthening my joint capsule, but they become more resilient.
I would probably go do it via like a box jump or a broad jump, I think.
What, onto their heels? You get them up higher. Jump it off the roof.
No, not landing on their heels, just landing normally, but then they get enough load through their heels for it to be, at least they get some sort of shock absorption through their something.
Well, I'm getting them hopping and jumping before then. I haven't had any that it's been more painful. Maybe they've gone somewhere else. They've just left me. The funny podiatrist is making me jump on my heels. I'm bringing the heel pain back.
Yeah.
Interesting. All right then. Well, let's leave it at that. What was that?
You haven't fully convinced me on that one yet.
No, that's all right. All right, cool. I will talk to you, Kelly, when I get home.
Sounds good.
It's been great.
I have to go.
Yeah. All right. See you later.
Bye.